Okay, everyone, to not penalize those who actually showed up on time too much, we will get going here. So welcome, everybody, to our February policy research talk. We took a break over the sort of end-of-year festivities, and we're now gearing back up. We have an interesting slate coming up this spring. So without further ado, let me turn it over to Inermit Gill, the Senior Vice President and Chief Economist of the World Bank, who's going to kick us off today. Over to you, Inermit.
Thank you, Dion, and I'm very, very sorry again that I'm not there. So I really don't have anything important to say at the beginning, other than to say that I wasn't at the World Bank for much of the time of the pandemic. And I always thought that the bank could have done a little better, Dion. I thought that the bank could have done better in helping low and middle income countries actually tailor their responses to the crisis, both on the health side, but also on the side of social protection, as well as the economic response, the fiscal and monetary responses, instead of copycatting advanced economies, right? So I was very interested to know what Damien and Dana were going to say about the health part of the response, because I really don't know much about it. But I do know that among the people at the bank who should be talking to us about these things, these are probably the two best people. So Damien is the acting manager of the Human Development Team in the Development Research Group. He actually has worked on HIV interventions in several African countries. So it's really good that he turned his attention to the COVID response. Then the other person you're going to hear from is Dina Ringgold, who is the Director for Strategy and Operations for Human Development. So she's a very important person for making sure that we don't make the mistakes that we made in the past, because she actually covers both strategy and operations for human development. She also has been the regional director for human development in Africa, and she actually worked also on the governance of service delivery. So again, the ideal person to speak about these things. So I was struck by the slides that Damien sent, and I don't want to steal his thunder, but the thing that struck me on his last slide, or last two slides, was there is no dichotomy between good pandemic preparedness and decent primary care. So he says that Thailand and Vietnam had the best responses, or among the best responses to COVID-19, because they had strong primary care systems that the population trusted. Okay, so I think that seems to be the key lesson that comes out of it. But I'm sorry to steal your thunder, Damien, by saying if that is indeed true, I'm very sorry to steal your thunder. But if that isn't the case, I am going to listen, and I'm going to change my tune at the end. But over to you, Damien, and then to Dana. And please chair the session, Dean.
Sure. But I won't be giving any spoilers. Just okay. Over to you, Damien.
Thank you. Thanks, guys.
Thank you very much, Inermit, for these kind words. And I assume the microphone works well? If that's the case, let me start. And good afternoon, everyone. It's my pleasure to present this policy research talk entitled Strengthening Health Systems for Pandemic Preparedness and Other Emerging Challenges. And I want to start this talk with, do you see, actually? No, there's, here, okay, thank you. I want to start this talk with this painting from Rembrandt. You can see it in the Mauritshuis in The Hague. In the Netherlands, the title is The Anatomy Lesson of Dr. Nicolas Tulp. I want to start with this painting, not only as a nod to my discussant from the Netherlands, but also because I want to apologize to you, because I'll be talking a lot about death and mortality. Inermit remember that I've reminded you that I've worked a lot on HIV/AIDS. When I was doing that, people were teasing me and were telling me, well, Damien, you always talk about death and sex. I'm sorry, but today I won't speak that much about sex, but quite a lot about death. So my apologies for that. More seriously, the reason I chose that picture is that I want to start this talk by doing some sort of an anatomy of the pandemic, the COVID-19 pandemic. And so the outline of the talk is that I will start with a retrospective look at the COVID-19 pandemic. I will raise some questions and lessons about health investments from the COVID-19 experience, and then I will switch to the current transition in the burden of disease that we are experimenting globally, with the rise, including the rise of non-communicable disease, or NCDs. And I will try to look at three questions. Basically, how to invest in health to minimize amenable deaths. I will talk about expanding health coverage, but I will also stress the importance of prevention and public health measures and the importance of quality of care using the concept of effective coverage. So I would like to start with contrasting these two numbers. On the left, we have 5.9 million deaths, and on the right, we have 18.2 million deaths. So what are these two numbers? They come from this paper published in The Lancet by the COVID-19 excess mortality collaborators. 5.9 million deaths. Those are reported official COVID-19 deaths during 2020 and 2021, whereas 18.2 is the estimate these authors are doing of the number of people who died during the same period, 2020-2021, because of the COVID-19 pandemic. They are using excess mortality methods to come to that estimate. So what are excess mortality calculations? They compare, for the same period of interest, the number of actual deaths to the number of expected deaths during the same period. The number of expected deaths is a projection based on the number of deaths in the immediately preceding years, and they add to that a linear trend, because in aging populations, the number of deaths tend to increase. That's considered as the gold standard in the analysis of COVID-19 mortality. And that, using these methods, they obtained this number, 18.2, which is 3 times larger than officially reported COVID deaths. It's important to realize that these excess mortality estimates represent a combination of different effects. The first one in blue are direct COVID-19 deaths that are due to an infection with the virus. To that, we add the number in green, which are the indirect COVID-19 deaths, which might be due, for example, to congestions of the health systems, delay in care seeking because people didn't want to go to the health centers, or issues with mental health. Now, to that number, you also need to subtract what is in brown, the averted deaths. Those are deaths that would have taken place in the absence of the pandemic, but did not occur because of pandemic-induced measures. We can think, for example, during the lockdowns, there might have been less traffic injuries, less violence, or other infectious disease. So it's important to realize that this excess mortality estimate combine these 3 components. So I said I will discuss a lot about mortality, but still it's important to acknowledge that the impact of COVID-19 went well beyond mortality. It included, as I mentioned, delayed care, the mental health burden, school closures, learning losses, lockdowns, economic and political shocks. I won't have the time to cover that, but I wanted to acknowledge it. So I want to start by taking some lessons from this comparison between the official COVID deaths and the excess mortality. So as I've said, the excess mortality estimate is more than 3 times higher than officially reported COVID-19 deaths. That basically says that even in the 21st century, our health and civil registration systems are still not very good at measuring the impact of such a major health event. And that's certainly, as a lesson, that's an encouragement to step up our efforts to mainstream civil registrations across the world. It would have benefits in terms of measuring the impact of future pandemics, but it has also many benefits beyond an accurate measure of mortality. It's important to register every birth so that the children can benefit from health and social services. Then using these numbers, I will quickly try to see how the deaths from COVID-19 were distributed around the world and try to ask how big of a number is 18.2 million. Obviously, it's a big number, but I will compare it to past events as well compare it to other recent health events. So this is a map showing the distribution of excess mortality across the world only in the country where using vital statistics allow such a calculation. So you see all the numbers with the gray shaded color. It's basically where such a calculation is not possible. But otherwise, looking at the colors and realizing that the closer you are to the dark red color, the higher the mortality rate. We see that mortality using excess mortality numbers was highest in Russia and some of the Eastern European countries. It was also quite high in South Africa, as well as in Brazil, Mexico, and Ecuador. Coming back to the paper I mentioned earlier in the Lancet, what they've done, so where there was vital statistics available to do the calculation, they are using that. And otherwise, in the other countries that were shaded in gray in the previous map, they've done a modeling exercise. And here again, the closer you are to dark orange, the higher the mortality rate. And the green color is lower mortality rate. So we see low mortality in Australia, New Zealand, China, in some African countries, and higher mortality again in Russia, Eastern Europe, the southern cone of Africa, Latin America, especially Peru and Bolivia, as well as Mexico. So if we take these numbers from the same paper and rank them by our World Bank regions and add a category for high-income country, this is what we get in terms of excess mortality per 100,000 people. In East Asia, excluding China and in sub-Saharan Africa, mortality was lowest. Then comes the group of high-income countries, and then not very much higher, MENA, South Asia, and quite higher, Latin America and the Caribbean, as well as ECA. So in a paper that we published with Gabriel Huissier and other co-authors, colleagues at the bank, we use both official COVID deaths on the left and excess mortality estimates on the right to look at how COVID-19 mortality was distributed by age groups, okay? And we've ranked the countries in descending order of income, with middle income at the top and richer country, high income countries at the bottom. We use colors to show, so all the share of deaths among individuals younger than 65 is in orange or brown. So working age people, the share of deaths among older people older than 65 is in different shades of green, And what we see is that in the middle-income countries, the share of deaths at younger age is higher. And that's controlling for the age structure of the population. So basically, mortality affected more working-age individuals in middle-income countries than in high-income countries. Now I want to step back a little bit and look in history and compare the COVID-19 pandemic with the Spanish flu or Spanish influenza that took place about 100 years before COVID-19, between 1918 and 1920. So on the left here, you have the two numbers I've already given you, 5.9, 18.2 million deaths, the two estimates. It's quite difficult to estimate mortality from the Spanish flu, but historians agree on a central estimate of about 50 million individuals, and the period was about the same length, and then that's the number in the middle, and then the two numbers on both sides are the low and the high estimate from historians. So of course, the world population was much smaller. 100 years ago, it was estimated to be about 1.9 billion, and currently we are about 7.9 billion. So to do correct comparison, you should divide the previous number by the size of the population, which I have done here, and we see that the difference is even starker in terms of mortality rates. The mortality rates were much higher 100 years ago. So, of course, we should expect that, because we should have done better, because over the last 100 years, there has been a tremendous progress in life expectancy, as it shown from this picture, just showing life expectancy over the last 100 years. The dark green line is for the world as a whole, and then you have this different line for each continent. And we see the levels are different, but the trend is the same. We have a gradual increase and substantial increase in life expectancy. So we should have done better, but even accounting for that, I would like to argue that we did better than 100 years ago, and I would like to argue that the vaccine played an important role in this. So let's remember, from the day the scientists performed the genomic sequencing of the virus to the first approval of a vaccine, there were only 326 days. That's very little by historical standard. So in a paper in the Lancet, Watson and Cotter tried to estimate the global impact of the first year of COVID-19 vaccination, looking at the period between December 2020 and December 2021. Again, they used the two methods that I have described before, using the official reported COVID deaths as well as the excess mortality estimates. Using the first method, the officially reported COVID-19 deaths, they estimate that vaccination prevented 14.4 million additional deaths. Using the second method, their estimate is higher, 19.8 million additional deaths. So basically, vaccination more than halved COVID-19 mortality, despite being introduced 1 year after the start of the pandemic. Another way to look at the benefit of vaccination is to do a returns on investment calculation. That's what SAR and others are doing for the New York City COVID-19 vaccination campaign, looking at the period between December 2020 and January 2022. They first calculate and estimate the cost, the direct cost of the vaccination campaign, also the indirect, including time lost to go for vaccination, time lost due to side effects of vaccination. Their estimate is $4.8 billion. Then they do two calculations for the benefits. The first one is just adding the direct and indirect healthcare cost, and that they come to close to $28 billion. And later, next, they also want to account for the life saved using the value of a statistical life methodology that is developed by economists to calculate how much people would be willing to live one more year. And doing this, they come to additional saving of $26.3 billion. So they calculate two returns on investment, including the value, the mortality saved. $1 spent saved $10.19. That's a return on investment of 1,019%. And without the life saved, $1 spent saved $4.27. That's a returns on investment of $427. As a point of comparison, the return on investment in the technology sector in the US was 16% in 2022. I should add that this calculation doesn't account for the potential cost of lockdowns, school and business closures that could have occurred in case of no vaccination. So it's probably an underestimate. So I think it's fair to say that COVID-19 vaccines were a game changer, but we should acknowledge that globally, we encountered problems with equitable manufacturing and distribution. My colleague Tristan Reed gave a policy research talk 2 years ago about this topic, so I will not cover it. I would refer you to it. And also, as we campaigned for vaccination, we encountered in many countries vaccine hesitancy, which is linked to the trust in the health system, which, if not addressed, might have lingering effects, including for other diseases. So it's important to verify whether and to what extent vaccine hesitancy has spread to other well-established vaccines, including childhood immunization. For example, in December 2023, there was an outbreak of measles in Kazakhstan, and there is some indication that this might link to a lower rate of vaccination for measles among children. So I will, as I move towards the end of this retrospective look at the COVID-19 pandemic, I want to draw 3 main lessons. The first one is a very basic one, a very simple message, which says it pays to invest in health. I've given you some example. That's something we knew at the World Bank, at least since the World Development Report in 1993, entitled Investing in Health. And we can debate whether the World Bank could have done better, but our institution delivered on this premise from April 2020 to March 2021. The World Bank Group committed over $200 billion to public and private sector clients to fight the impacts of the pandemic. Second lesson I want to take is that government play an important role, but individual behavior still matter a lot. So the government played a role in establishing and enforcing lockdowns. In some cases, maybe not enough in providing social support during those lockdowns, in maintaining essential services during the crisis, even if those services were under stress. I'm thinking, of course, first and foremost at the hospitals, and also in purchasing the vaccine and distributing them. The private sector also played a role. I'm thinking here about the development and the manufacturing of vaccines. But we've seen that individual behavior still matter a lot. Most of us want to be vaccinated, but as I've discussed, there was also vaccine hesitancy. Most of us followed lockdowns and mask mandates, but there was also some resistance. For example, this paper by Abaluk and others shows how interventions to persuade people to wear masks were important in Bangladesh. Third lesson is that trust matters. So I'll illustrate this using first a paper by Arsenault and others. They use people voice surveys, phone surveys, in 14 countries ranging from low to high income. They find that greater healthcare use, having a regular and high quality provider, using other preventive services, confidence in the health system and in the government, positively correlated with COVID-19 vaccination. There is also some evidence that countries which had been confronted and responded to previous epidemics, such as the SARS epidemic in East Asia in 2003 and the Ebola epidemic in West Africa between 2014 and 2016, were better prepared. There is also some evidence about the role of politics in building trust or not building it. I'll mention two examples without going too much in details. I'll mention Brazil and the United States. So let me finish about COVID-19 by just giving you some perspective about that famous number of 18.2 million deaths. That was for the period 2020-21, 2 years for COVID-19. If we compare with HIV/AIDS over a much longer period, more than 30 years, between 1991 and 2022, the estimated number of deaths is 14.4 million. And then Ebola that I just mentioned in 2014-16, the death toll was 11,325 individuals. And SARS in East Asia in 2003 was 774. Now, I want to take this number of COVID-19 estimated excess deaths and just focus on the excess death in low and middle income countries. That's the number here on the top on the right is 15.6 million for the 2 years, 2020 and 21. And I will pivot to other disease by comparing this number that happens to be the same by chance to the number of total avertable deaths in low and middle income countries. So those are deaths that could have been avoided in the year 2016, just 1 year, but it's just before COVID, and it happens to be the same number. So let me take that number and further decompose it. That's what Margaret Kirk and others are doing in this paper published in the Lancet. So they take this number of total avertable deaths, 15.6 million for 2016. What they first do is they compose that number between deaths that are amenable to healthcare, that could have been treated in healthcare. They come to the number of 8.6 million or 55%, and then deaths prevented. Deaths preventable by public health intervention, that's 7 million or 45%. Then the number of deaths amenable to healthcare, they further divided in two categories: the deaths due to the non-utilization of health services, that's 3.6 million or 23%, and the deaths due to use of poor quality services, that's 5 million or 32%. So I'm not going to go too much into the detail of how they are doing this. It's another use of excess mortality. What they are doing, they're using data from the 2016 Global Burden of Disease study, and they calculate mortality amenable to personal health care for 61 SDG condition, medical condition, and they compare the case fatality. The case fatality is the number of deaths divided by the number of people suffering from a specific disease. They compare this case fatality between each low or middle income country with the corresponding case fatality for 23 high income reference countries with strong health system. They further use data on healthcare utilization from population surveys to separate the deaths due to non-utilization and deaths due to poor quality. If we take those numbers and divide them by region, this is what the picture we are getting. So in dark blue, we have the deaths per 10,000 people due to low quality of healthcare. In light blue, we have the deaths due to non-utilization of healthcare. And in yellow, we have deaths due to insufficient prevention, issue with individual behaviors, environment, or lack of preventive care. There are two main messages from the paper. The authors, they mainly focus on quality of care. They say that in low-income countries, expanding healthcare coverage does not necessarily result in better outcomes, even for conditions highly amenable to medical care, and therefore health system quality must improve. I fully agree with that message, but that quality of care matters, but I would like to add also the one that prevention and other public health intervention matter. So to finish with the estimate from this paper, here is a map showing in the world where the mortality due to poor healthcare quality is highest. So the countries in gray are the 23 reference countries with strong health system. And then the closer you are to the dark blue color, the higher the mortality due to poor quality of care. We see that's highest in many countries in Africa, especially in countries in West Africa and Central Africa. It is also quite high in Afghanistan, Pakistan, and India in South Asia. So now, moving to other diseases than COVID-19, it's important to realize that COVID-19 occurred in the middle of a transition in the burden of disease. Overall, the world experienced a rise in the, of non-communicable disease, NCDs, also called chronic disease, such as cancer, diabetes, hypertension, heart condition, and others. Their characteristics are that they are of long duration, and it's for successful treatment, it's important to have early detection. NCDs will become even more prevalent with aging populations. Non-communicable disease kill 41 million people each year. That's equivalent to 74% of all deaths globally. I don't like too much that statistics because unfortunately we know we'll all die and we'll all die of something, but I think it's more important to focus on premature deaths. So the second statistic I think is more telling. Each year, 17 million people die from an NCD before age 70, and 86% of these premature deaths occur in low and middle income countries. As I sketch this transition in the burden of disease, I also want to mention the consequence of climate change on health, including air pollution, droughts, heat wave, etc. I won't have the time to discuss this in detail today, but I wanted to acknowledge it. So let me sketch this transition in the burden of disease using three of these graphs. Here we are looking at low-income countries, and we are not looking at deaths this time. We are looking at DALYs, which is the acronym for Disability Adjusted Life Years. So it's the number of years lost because of a disease, and it's adjusted for the years you live with a disability because of the disease. It's in million. We go to the period from 1990 to 2019. I'm not going to go over the list of disease, but on the left we have the communicable disease, including also the maternal disorders, neonatal disorders, and others. On the right, we have the communicable disease that I've mentioned before, hypertension, cancer, cardiovascular disease, diabetes, etc. What we see in low-income countries is over time a decline in the share in the burden of disease from communicable disease and a gradual increase from the NCD. On the NCD side, it's still important to note that in the low-income countries, the total number is still higher on the communicable disease side. So I don't want to discount the importance of communicable disease, especially in low-income countries, but the trends are clear. Same picture for lower middle-income countries. The trends are the same. Decline on the communicable disease side, increase on the NCD size. Here, the total number by the end of the period is actually higher on the NCD side. And then finally, the picture for upper middle income countries, you see a stark decline in the share of the communicable disease in the lost DALYs, and an increase in the numbers and the share for the NCDs. So of course, those numbers were stopped in 2019 before COVID. I've just said, a rise in the share of non-communicable disease, and COVID-19 was an eminently communicable disease, a new one. So that sort of changed the picture, of course, at least for 2 years. But it's also important to note that there are important interactions between COVID-19 and non-communicable disease. People suffering from NCDs are more vulnerable when they're infected by COVID-19, more likely to end up in the hospitals or to die. We are learning about long COVID that might be a new chronic condition. We've seen the health and mental health consequence of the lockdown, as well as the non-health consequence of the lockdown on poverty and education. So COVID-19, I've tried to argue, reminded us that it pays to invest in health. Now, what I'd like to do is to spend the rest of my time trying to ask how best to invest in health, given the transition in the burden of disease that I just presented. So I think the transition in the burden of disease stressed the importance of prevention first. Prevention is more effective in terms of disability-adjusted life years, DALYs, saved, and it's also more cost-effective than treatment. Prevention can take place at 2 levels, first at the population level, and then at the interaction between the population and the health systems, where both the demand and the supply side can play a role. So let's first think about the intervention at the population level, so-called public health intervention. One first set of intervention aims at reducing risk factors. We're thinking about reducing smoking, alcohol and drugs consumption, unsafe sex, bad eating and drinking habits. Or they could also increase good habits, good health habits, such as exercise, healthier nutrition. They could encourage hygiene and, for example, mask wearing during pandemics. It's important to note that this type of intervention have benefits not only for the individual, but also for others, since there is a positive externality. There is also intervention to reduce environmental exposure. We are thinking about reducing unsafe water, pollution, etc. In terms of pandemic preparedness, epidemiologic surveillance is very important, being able to detect when a new virus might occur, a new outbreak of a known virus might occur. And for that, the concept of One Health is important. One Health is basically looking at the same time at human and animal health and their interaction. We know that many of the recent pandemics were triggered when a virus jumped from animals to humans. So these interventions are mainly on the demand side. It's first about providing information. When it's not sufficient, financial incentives could play a role. We can think of cash transfer potentially, but I would argue that when feasible, especially for bad habits, taxation is the most efficient instrument. We've seen that tobacco taxation was very instrumental in reducing smoking rates. There are many experiments currently with taxation, for example, for sugar-sweetened beverage. There is also some role on the supply side for supply side intervention, for example, the vaccination campaigns. Prevention also occurs at the interaction between population and health system, and where both demand and supply side can play a role. We're thinking about antenatal care, stressing how important it is for pregnant women to come to regular checkup before they deliver. Immunizations, I've mentioned the COVID vaccine, but there are also all the child immunization or the flu vaccines for adults. I want to take this opportunity to celebrate the introduction of the new malaria vaccine for the first time in the official child immunization calendar in Africa. That was in Cameroon at the end of last month. Also very important is the early detection of non-communicable disease, such as cancers, hypertension, etc. It's important also to address antimicrobial resistance, which can be triggered by misuse or overuse of antimicrobial drugs. So here again, we need information on the need of preventive care. People should know that it's important, for example, to do regular screening for chronic disease. But when it's not sufficient, financial incentive could be used, for example, cash transfer. But sometimes simpler and cheaper intervention, such as personalized invitation, can be as cost-effective. So I'll give you one example from a study we conducted with World Bank colleagues in Armenia, where we compared personal invitation and cash voucher to encourage hypertension and diabetes screening. On the left here, so we are looking at individuals who are aged 35 to 68. That's the age when people are supposed to do a yearly screening for hypertension and diabetes in Armenia. We looked at people who are not been screened in the last year, and we followed them over 6 months. In the comparison group, just 3.5% of people screened. In orange, you see people who had received a personalized invitation, was an invitation signed by a doctor, by their doctor, telling them how, where, and when, and under which condition they could come for the screening, and that the screening was free. You see that the screening rate increased by 15 percentage points to 18.5%. And then there was another intervention where to the invitation we added a $10 conditional voucher. They could redeem the voucher in pharmacy chains. And basically we told them, if and only if you are coming for the screening, we will give you, after that, this $10 voucher. And we see that the screening rates sort of increased by another 15 percentage point. So the impact was larger if you add the conditional voucher. But when we looked on the right at the average cost per person screened, there we see that because the conditional voucher, of course, costed $10 and you needed to bring it, the average cost per person screened was similar, about 60, a little bit more than $60 per individual. I want here to make an aside about obesity. So we all know about the new drugs made from semaglutide, the brand names are Ozempic and Wegovy, and a fair question in whether they are a game changer. So we know obesity is important and it's killing many people, not only in rich countries. And the map here on the left, you see the share of deaths attributed to obesity in 2019. And the closer you are to the red color, the higher. It can go up to 30% in some of the countries in the Arab world, but many other countries, we have a large share of deaths attributable to obesity. So it's an important issue in many countries in the world. But the current prices are quite high. They are between $215 and $700 a month. And that's, you could say that's way too expensive for low and middle income countries. Isn't it better to focus on prevention and behavior change? My answer is maybe, but that debate reminds me of a debate that took place when I joined the bank around the early 2000s, where the same reasoning was made for antiretroviral treatment for HIV/AIDS patients. The prices were sky high, and people were saying low and middle income countries cannot afford that. We should focus on prevention and behavior change. Turns out the price went down, and no antiretroviral treatment is available everywhere, and it's estimated to have saved 18.6 million lives between 2000 and 2021. Now I will finish this talk by looking at the quantity and the quality of healthcare. Some of the evidence I will take is coming from a policy research report that we wrote with many authors here at the bank, entitled Improving Effective Coverage in Health, Do Financial Incentives Work? I presented with Ishani Kanpal this report in a policy research talk in May 2022. So if we think about the quantity of healthcare or health coverage, it's first a supply side issue. We need the right number of health centers, of doctors, nurses, the right equipment. But even when centers are well staffed and well equipped, staff must provide sufficient effort. It depends on their intrinsic motivation, but also on their extrinsic motivation, their salaries, but also the potential role of performance-based financing, or PBF. Our institution, the World Bank, has invested substantially in that reform, and that report is looking at the evidence. I won't go into the detail, but note that even if you make an effort on the supply side, there is also the need for patients to come to receive health care, including for preventive care. So for uncomplicated case, financial incentive for patients to visit primary care facilities could be used and have been used. So that's what we are looking in the report. In that exercise, we compared financial incentive offered to patients to visit clinics on the demand side. We compared them to incentive offered to providers to increase and improve service delivery, like performance-based financing on the supply side. So we did this exercise for maternal and child health services. What do you have in these graphs? On the right side, you have a demand-side intervention, conditional cash transfers. On the left side, you have a supply-side intervention, performance-based financing for health providers. In the middle is a voucher, which is a hybrid between the two. The patients receive a voucher that they can use to receive free services, and then the health center can cash the voucher. We look at 6 maternal and child health services, modern family planning, facility delivery, 4 antenatal care visits, 1 postnatal care visit, maternal tetanus vaccination, and full child vaccination. What do we see? Overall positive effects, most of the time, but not always statistically significant as indicated by the stars. But the effects are overall a little bit modest. And if you look at the point estimate, if anything, the point estimates are somewhat larger on the demand side, the CCT side, and the voucher side than on the supply side. Let me then look at quality of care using the concept of effective coverage. It's a concept that requires that everyone in need of a particular health service is getting it in a timely manner and at the quality necessary to obtain the desired effect and the potential health gain. So it's basically, we go from utilization, which is the percentage of the population using a service, to coverage, which is the population in need using a service, to effective coverage, percentage of the population in need using a service and getting the optimal treatment. I'll show you using an example, the example of hypertension in 5 East Asian countries, that you can miss an important part of the picture if you only look at quality or at quantity. So here we start with quantity or coverage. So we are using WHO stepwise survey. We are looking among the people who suffer from hypertension. The survey measured their blood pressure, the percentage which receive treatment. And you see it varies a lot. It's quite high in Cambodia and Vietnam, but it's much lower in Mongolia, Myanmar, and Timor-Leste. Next, we look in orange at quality. Quality is among those who receive treatment, the percentage with their hypertension under control. And here the picture is somewhat flipped with better results in terms of quality for Myanmar and Timor-Leste. But I would argue that the two numbers are misleading or not sufficient. What you need to do is multiply the two numbers, get their product to get at effective coverage. That's what we do here. When we multiply the two numbers, we get the number in gray. And here, clearly, the numbers are fairly low. In Cambodia and Vietnam, it's between 10 and 20%, and it's below 10% in Mongolia, Myanmar, and Timor-Leste. So to finish with quality of healthcare and effective health coverage, again, it's first a supply-side issue. You need to train high-quality doctors and nurses. You need high-quality equipment. But even when well-trained staff and well-equipped health centers are available, staff must provide sufficient effort to reach minimum quality. Again, it depends on intrinsic and extrinsic motivation, and performance-based financing might play a role. But patients could also be better informed of what minimum quality standards are and which facilities satisfy them, so we could think of information interventions. Now let me finish by repeating the three lessons I took from the COVID-19. The first is the simple message that it pays to invest in health. The second one is that government play an important role, but individual behavior still matter. And the third is that trust matter. So here is the thunder that Indermit stole, that there is no dichotomy between pandemic preparedness and primary care. Thailand and Vietnam offered one of the best response to COVID-19 because they had strong primary care system in which the population trusted. My main message in terms of universal health coverage is that the quantity and the coverage of healthcare provided remains important, but prevention and public health measures could help avoid a large share of the burden of disease, especially with the growing share of NCDs, and that quality of care is at least as important as quantity. And I'll finish with this main policy message. Prevention is key, especially but not only given the rise of NCDs, the importance of vaccination, of public health measures such as information, but also taxes on unhealthy behavior, and the importance of early screening. Quality of care must be an essential component of universal health coverage, and quality of care builds trust in health systems. And finally, strong primary health care systems are the foundation of pandemic preparedness. Thank you very much.
Thank you, Damien. That was an incredible amount of territory that you covered. And Dina's going to respond to each and every point you made. No, Dina, over to you. Just after Dina's given her comments, we're going to open it up for Q&A in the room. If you're online, feel free to sort of raise your hand virtually or put a comment or question in the chat, and we'll manage as we go forward. So, Dina, over to you.
Okay, thank you. Indermit, Dion, Damien, for the invitation to be part of this. This was extremely thought-provoking and really a chance to reflect. I should start by giving the caveat that I am not a health specialist. So my perspectives come from my experience as HD Regional Director during the pandemic, covering West and Central Africa, where I learned a lot on the job, and then currently as HD Director, where, you know, I think we're still trying to come to grips with what happened. And so I think this kind of a conversation is extremely helpful for reflection. So let me just start by saying that I think it's really welcome that we're talking about the lessons from the pandemic. I feel like this is a topic that no one, Gabriel and I were discussing, no one really wants to talk about anymore. I think we all went through it and we want to move on. But I think that leaves us in, you know, the difficult place of panic and neglect conversations. And I've, sorry, I need to tell whoever's trying to reach me that I'm not talking on the phone right now. We're reenacting some of the panic and neglect conversations about the need to invest in pandemic preparedness that we had well before COVID, they're coming back. So I think it's really important to remind ourselves why this matters. And, I think it's really striking that there was a work by CGD that suggests that there's a 50-50 chance of another respiratory pandemic on the scale of COVID during the next 25 years. So we are all likely to go through this again, which is terrifying. I think it's also striking that the mortality findings that you shared, that there's very little correlation between the Global Health Security Index and preparedness and how countries fared during the pandemic, and that really trust is key. And so I think in thinking about, the so what and what do we do, putting that front and center is very important, but also extremely challenging. So just reflecting on my own experience, I think these trade-offs that you're pointing to between the need to invest in pandemic response and preparedness and health systems and quality of care are real. And when I was going through this in the Africa region, I really saw firsthand how countries struggled to respond to the immediate needs of the pandemic and manage weaknesses of health systems that really were fragile or non-existent. And, I think there were two kinds of, at least there were lots of different kinds of countries, but two come to mind. One is that, there were countries that had existing healthcare systems, primary healthcare, like Cabo Verde, which was one of the countries that I got to visit during the pandemic. They had, it's a very small island country, well-resourced in some respects, but they also had extremely strong primary care. And they were able, once they got access to the vaccine, which is another story, they were able to ramp up to, far surpass OECD vaccination rates really, really quickly. So having that system in place mattered a lot. The second was countries that were able to use the pandemic response to reinforce and strengthen aspects of their systems, even if they were weak, and really go through a learning process. And the one that comes to mind was Cote d'Ivoire, which was the first country that I visited in November 21. And their initial vaccination response was really slow. They had access to vaccines, but they just couldn't get them out. And so they did some thinking about why that was and started to really get to the population. So they had mobile vaccination clinics. They expanded centers in communities, and they were able to catch up pretty quickly and be one of the countries that had a higher rate of vaccination. So I think, these interactions that you point to between pandemic response and health systems and health services are really really important. And I think the tragedy in Africa was, that for quite a few countries, the pandemic really put health systems under strain, and this led to further gaps in, basic immunization coverage, non-COVID childhood vaccines, and other kinds of drops in access to services. So you talked about, strong primary health care as the foundation of pandemic preparedness. So these things being linked. Now, my colleagues in H&P, and some of you are here, and I hope Tim and others will speak up during the conversation, we call this resilient health systems, really packaging prevention and preparedness together with systems that are able to respond. It's really this sweet spot of win-wins that you pointed to in the case of, you mentioned Thailand and Vietnam. So just thinking about, what we can do to help countries get to these win-wins and build resilient health systems, I think there's maybe three areas. One is around financing, and you have your headline, it pays to invest in health. I think that's great. Obviously, the challenges are real in lower income countries. Less than 2% of GDP is spent on health. And we know, because of work that colleagues have done, that because of the fiscal outlook in developing countries, this is unlikely to increase between now and 2027. Their projection is that health spending is going to remain at about COVID or pre-COVID levels. So fiscal space is really limited, and so this is really an exercise in thinking about how countries can spend more if they can, but more importantly, how can they invest better, and how can they think about some of these trade-offs. And I think, that's the challenge that your presentation gives us is, given the needs and given the shifting burden of disease, how do you prioritize specific trade-offs in health investments, which is, I think, the second area. What are the investments that really add up to resilient systems that respond to shifts in the burden of disease and also increasing health emergencies. And we're talking about pandemics, but I think, the climate risks and the need for countries to build resilience to climate-related health challenges are just as challenging. So I think one element of this, which I think it gets at this point you made about the interaction between the population and health systems, for me, is around investing in the health workforce and community health workers. I think that's important not only for the kinds of services they can provide, but it's community health workers who are also able to contribute to trust. And I think there's some examples and anecdotes from the pandemic. Nigeria, for example, was able to mobilize 50,000 community health workers who had been trained to deliver polio vaccines to deliver COVID-19 vaccines. So, having these people who can be trained and retrained and sent out to communities to deliver services is really important. And I think, if you look at our health portfolio, we're increasingly working in this area and thinking through, the supply side incentives for providers and the issues around, behaviors of providers and incentives and quality. But I think this is an area where, we need to think together about what really works. I think continuing on this idea of trust, I think some of the work of the Embed unit and thinking about behavioral interventions, we saw some thinking about this during the pandemic and what nudges and messaging and engagement with people in communities leads to less hesitancy around vaccines and more take up. I think there's a lot there to think about, especially at this intersection that you talked about. The other is what technology can do and the role of digital and AI in health. One of the examples in the collapse and recovery report that Norbert and colleagues did on the impact of the pandemic, one of the examples there is in Pakistan, where in the first year of the pandemic, over 1 million kids were left unvaccinated, but they were able to use an electronic registry of immunization to find kids and vaccinate them, and they caught up pretty quickly. So, what are these instruments that can leverage technology to help health systems be more agile and resilient? And then I think the third area is around increasing equitable access to, the kinds of medical countermeasures like vaccines that you talked about. And I think there's a lot of lessons, and I'll watch Tristan's talk that you link in your report because I missed that. But, I think I completely agree that the rollout of vaccines was a game changer, but in our countries, it was a real struggle, right? So, 45% of Americans got access to one dose of the vaccine before 1% of Ethiopians did, right? So, and that's just, one number. It was really striking how African countries and developing countries at large really lagged behind. And we were able to respond through things like, the innovative partnership that we had with the African Union under the AVAT arrangements. And the bank was able to, help countries get access. He just retired, but Enzo, our chief procurement officer, was just incredible at helping countries, connect with pharmaceutical companies to get contracts, and all of this was very important. But as we think forward and think about how the bank can do better next time, I think, questions around should we be together with IFC, helping countries build manufacturing capacity so they can more quickly get access to vaccine. What kind of at-risk financing mechanisms are there so that the bank can help countries compete on a level playing field in the market next time they need to get vaccines, and so on. So I think some of these ideas are, that I throughout in the area of what makes a resilient health system are very much embedded in the Health Emergency Preparedness Global Challenge program, which you may have heard about. And I think we're already working with DEC on some elements of that around impact evaluation and what kind of a monitoring framework. And I really think we need to continue that. There are sort of 3 areas that are envisaged under that Global Challenge program, which are going to be made available to all countries. The first one's around core public health services and systems, and I think there's a very blurry line, as you pointed to, between what's primary health care and what's essential and what's around preparedness. I think they really go together. The second is around access to financing, and the third is around what are the tools, the countermeasures, the vaccines, diagnostics, and other things that countries need to be able to be prepared for any kind of health emergency. So we're joined at the hip, I guess, on this, and thanks so much for inviting me.
Thank you, Dina. And thanks for bringing up the Global Challenge Program, because in fact, this is the first of what I hope is several PRTs, policy research talks, that we do that are actually linked to the GCPs. So I don't know if it was subtly in the title that this was a Global Challenges Research Insights talk, and we hope to have a few more of them actually on all of the GCPs. So let's open it up. I see, Intermit, you've unmuted yourself, so I presume that means you're chomping at the bit for a question.
No, I have a question, but I can wait for the others. The others are actually, yeah.
Well, why don't you start, and we'll see. Are there any questions in the room? If you want to just raise your hand so that I have a sense of... okay, there's a couple in the room. So, Intermit, why don't we start with you? We'll do a few more in the room, and then please, if you're online, please raise your virtual hand or let me know in the chat that you have a question. So, Intermit, you kick us off.
So, so I'm going back to the point that I see in Damien's PowerPoint, which was that Thailand and Vietnam had strong primary care systems. So then I was thinking, okay, strong, let's say that strong means strong has a quantity aspect to it and strong has a quality aspect to it. So my question to him was, say that you have, or during a pandemic, relative to normal times, does quality of care matter more than the quantity? Because then, I guess if the answer to that is yes, Damien, then one of the best ways to prepare for a pandemic is to continue to invest in primary health care rather than something, something which is specific to a pandemic, but invest more in the quality part as compared with a situation where you're not expecting to have pandemics. Stop there.
Okay, thanks. Usually we actually turn it back to the speaker right after the discussion. I'm sorry. So we'll incorporate any responses to Dina in this round if you don't mind. Apologies for that. Tim, and then Jed, and then Gabriel.
Sure. Thanks, Damien. And glad that you're not talking about death and sex. You're talking about death and taxes. So you've got an additional aspect there. We worked together in the early AIDS things in Burkina and elsewhere, so it's great to hear your perspectives. Maybe an observation and perhaps a question. Great to be bringing evidence on this. I think there's a challenge both in messaging and even in these GCPs on how to frame this kind of interaction between pandemic preparedness and health systems. And in a sense, it's a more complicated challenge. It's more difficult than health and, say, education, when you just talk about learning losses and skills, Because in health we say, well, there's pandemic preparedness and there's health system strengthening and there's primary care and there's climate resilience. And I think sometimes the messaging gets, and that distinction is challenging. And I think it's non-trivial because as we move into this GCP, Global Challenge Program, there will be those thinking, if I'm doing a Global Challenge Program focused on, a country director says, as long as I'm doing pandemic preparedness and strengthening my laboratory and other systems, then I'm good. And the health specialists will say, no, you need to be looking at the systems. And so I think there's a messaging issue, but there's an evidence issue. And I'm wondering, do you have anything coming out of is there more we can say on the evidence side about the relative balance or the importance in terms of the type of pandemic, including as you move from a focused pandemic, outbreak like Ebola or, SARS, where, rapid response and control, to where you're in a much more generalized situation where, it's no longer about border control, but it's about the entire health system's response. Do we have any insights, or is there a way that we can bring in the evidence to think about that? And then I think there is a challenge on the overall messaging. Other topics would be interesting to discuss, but I think that's something I'm kind of, wrestling with a little bit. Thanks.
Great. Okay. Thanks, Damien, for the great talk, and Dina for the fantastic comments. Just another thought to throw into the mix that's already been started by Indermit and Tim. And I, of course, don't want to take away from the usefulness of investing in health systems because, as you're arguing, investing in pandemic preparedness are, in many ways, is a general investment or can be seen as general investment in health systems with many returns. But from the pandemic averting or minimizing perspective, you did mention briefly the importance of the human-animal interface, either with wild animals or with domestic animals. And I guess the layperson in me would think, well, that could be a very efficient use of funds to try to minimize contacts there, since most likely the next pandemic will come from a zoonotic origin. So I'm not familiar, but can you speak a bit about the relative cost effectiveness of investments in that domain as well? Thanks.
Thanks, Jed. Let's go to Gabriel, and then we'll turn it back to Damien, and then we'll open it up for another round. So please think of your questions.
Yeah, so just I think echoing kind of everybody else, and in particular Dina, on this general point that I think it's quite frustrating that the pandemic is so much in the rearview mirror now, and we just haven't been doing this sort of analysis of what happened, what do we do right, and what can we do better next time. I think that covers a whole lot of ground, including on the health response. And just on this question, I definitely want to believe the basic idea that investing in the health system is going to help with pandemic preparedness, but I'm skeptical of that. Since we're among friends, I think I can express my skepticism on the general point. I know we all look at the pandemic in terms of our own personal experience and with the bank. So I was in Manila at the beginning, it's HTPL. So January 2020, we were all kind of looking around to say, okay, how do we evaluate this? How do we evaluate how well our countries are prepared? And the go-to reference was the Global Health Security Index. So we were going country by country and saying, okay, Thailand looks pretty good, Malaysia looks pretty good, Philippines not so clear. And then maybe 6 months later, or later in 2020, I looked at the correlation between the GHSI and outcomes, and that was 0. And there's now a bunch of papers which show the same thing. And as you pointed out, the one thing which really comes clearly through in any kind of cross-country analysis is a trust measure. So countries that had higher measures of trust did better, but nothing in the GHSI, which is sort of a bunch of measures of basic healthcare quality and quantity. And then when I was in Colombia a couple of years later, the team did a pandemic preparedness report looking at all the questions of pandemic preparedness for Colombia. And their set of recommendations was basically improve the healthcare system in many, many different ways. And so I sort of put those two things together. And my feeling was, well, how do we know these things are actually going to help for pandemic preparedness? And that's still the question that I have. And I also worry a little bit that selling that health systems investment story is going to cause us to neglect other things that we could do in terms of pandemic preparedness, where we do have a little bit more evidence. I mean, one thing, for example, is wastewater surveillance. I think the evidence is pretty clear that that's low cost, high benefit, also of benefit not just during a pandemic, but also for understanding general disease trajectory at other times. So I just want to share my skepticism on that major point.
Thanks. Back to you, Damien.
Yeah. Thanks a lot for the comments, questions. It's a lot to cover and to answer. I apologies if I don't do it fully. So then some quick response. So on the yes, I mean there is the issue of financing in the fiscal space, and maybe we had some increase of that fiscal space during COVID, and now we are back to before. That's a little bit this panic and neglect cycle. One point is that, for example, the so-called sin taxes that I advocated are a way to increase the fiscal space. I mean, in some countries where not many people are smoking, or not people like in Africa, or many people are drinking soda, that might not bring a lot of money, but that's one way where it's a win-win. You increase the fiscal space, and you reduce unhealthy behavior. The community health workers, I fully agree. That's something I wanted to cover. Then Dion told me you're already covering a lot. But I think that, I mean, there is a lot of evidence, especially when we don't have enough doctors and nurses, that we could do a lot more with community health workers. There is an important issue, is how you compensate them. And I know we have the issue of but most of the successful experiment with community health workers have been like from special interventions from donors where they were well compensated, and there is less evidence that if they are not paid a regular amount of money, not necessarily a salary, it's difficult, and we know that health ministries are very reluctant to put more people on their payroll. So that's a question that needs to be addressed. Intermediate, the quality versus quantity during the pandemic, I think it was a combination of both. I mean, it was clearly at some point just quantity. We needed the number of vaccines. At some point early on, we needed the number of beds, but we know we also needed for example, when I was talking about equipment, we know that even if we had beds, we needed oxygen. So so it's a combination of both. But so a lot of discussions have been about,
I should clarify my question.
Okay.
Clarify my question, Jamie. You said that trust becomes a more important thing during a pandemic. And somewhere along the way, you also said that trust and quality are more highly correlated than trust and quantity. So that's why I was thinking that why aren't you connecting them and saying, well, a good way to prepare for pandemics is, of course, to increase the trust in the system. And the shorter cut to that is to increase the quality. Because, I could imagine somebody who does not have easy access to the system during normal times might actually make an effort to actually access it during a pandemic, but they won't make that effort if they didn't trust the system.
Trust is
we can't hear you.
Sorry, let me repeat. Independently of trust, investing in quality of healthcare is already important, just given the number I've given from that paper by Margaret Kruk and others. Then I think you're right. I mean, investing in quality is the way to build trust, in the sense that, and I think also, for example, we are working with Aditya in East Asia on a report on the primacy of primary care. So basically, the way you develop trust in a health system is having access to a regular primary care provider. You establish a relationship, you trust that person, and then when that person tells you, well, you should wear a mask or you should come and get vaccinated, you should come and you are 35 or 40, you should come for screening for diabetes or hypertension. The population are more likely to trust them. So the team, so this interaction between pandemic preparedness and quality or strong health systems, I think we should avoid that dichotomy. I see it coming around. So it's, I think Jet and Gabriel, well, Gabriel is more skeptical. So I believe, I don't have a strong evidence. I provided evidence from that paper by Arsenault and other where COVID-19 vaccination rates were positively correlated with having a regular primary physician, with trusting the health system. So I do believe that that works hand in hand, trust and quality and pandemic preparedness. I agree that we need other things, for example, One Health. I'm not a specialist, but so I don't know the cost effectiveness. I'm sorry. It seems that it could be also very cost effective. Also, I don't know how costly it is, for example, or acceptable it would be to cut every wet market in Asia. And I don't know how feasible it is, but clearly in terms of surveillance, it should be feasible, including wastewater surveillance. So I guess I've touched a little bit each of your points, but not all of them.
So we have a couple more minutes. I want to give people online a chance. I think somebody raised their hand and then put it back down, but since we have a minute, if you have a 30-second question, now's a good time. Otherwise, I do want to ask Dina if she has any rejoinders to any of the questions or comments. Do you have? Okay, Dina.
No, look, I think this is asking all the right questions, right? About, how to prioritize and phase investments, and, throwing in One Health is absolutely relevant, and it's a big piece of the work that's gone into the GCP together with our ag colleagues, but we need to look at these questions of trade-offs and cost effectiveness. And I fully agree with Tim that this framing is really important, and I see it tripping us up even in the conversations internally. Are we putting? I heard it, from important people in the institution. Are we, throwing our eggs at preparedness at the expense of health system strengthening, UHC, primary care? And I think we need to be able to map how these things reinforce each other, and have some sort of a framework for prioritizing within these two subsets that are really overlapping interventions. So I think you're asking the right questions, and we need also, you rightly put it also in the context of the shifting burden of disease, right? And we have a lot of different patterns going across, right? The regions and countries. So thanks for throwing these ideas out, and I think we need to follow up and sort of decompose some of these questions further. Thanks.
Thanks, Dina. Intermit, I'll turn it over to you in 1 second, but just let me, in conclusion, from my perspective, say this has been incredibly insightful, but also I've really enjoyed the research operations joint discussion that we've had in this session, bringing together kind of all this evidence and research, and then both your experience but other people's experience in the room, actually literally going going through the operational side during the pandemic, but also sort of reflecting on it together afterwards. So I really thought that was great. And you know, as we think about the Global Challenge program, I think jointly thinking about how to sort of shape that and what that's going to involve, both on the operational, but as well as the knowledge agenda that's associated with that. I think this is the start of that conversation, certainly not the end. But Inamit, over to you to wrap us up. Thanks, everybody.
Yeah, thank you, Dion. So I wanted to go back to the point that I started with, which was, you know, to try to sort of see whether or not during the pandemic, did we kind of get herded into saying the same things for all countries? And those things were basically the things that we were hearing the medical practitioners as well as the public health officials and others say for advanced economies, right? So I thought that's an important question for Dina, because so as strategy for the next time round, I think it would be really important to actually see whether we would do the same thing that we did the last time or not. That was one thing. The second thing, and there, I thought it was very important to sort of look at these data that Damien presented, and he sort of showed he showed the excess mortality numbers being quite different, for example, especially for LAC and ECA. And that kind of surprised me, because I would have thought that those were the two regions where the quality, at least, of the healthcare systems would have been better as compared to the others. But maybe I'm missing something. The point that I'm trying to sort of make is that would there be region-specific pandemic strategies? So rather than think about this in a very global way, would it help us if we sort of thought about it for a subset of countries? And I think that you could sort of think about it as by region, because that's a good proxy for quality or some other indicators of primary, secondary, tertiary healthcare. Or you could think about a better categorization of saying that, okay, you know, we're actually going to find this is the best indicator of how well prepared a country is for a pandemic. It's not the ones that we were looking at, you know? And that's the indicator then that we should really be targeting and trying to sort of improve. But those are my lay observations, and so I will leave the debate to the experts but I leave still with a dissatisfaction in terms of whether or not we are actually learning the lessons of the pandemic. And I'm not just talking about the healthcare systems. I'm also talking about education. I'm also talking about social protection. I'm also talking about fiscal policy generally and monetary responses. I'll stop there.
Thanks, everyone, and see you at our next policy research talk. Thank you.
Thank you, Dion. Thank you for sharing so well.